Warm welcome to you all. My name is Phillips and I'm the Head of Health and Social Care here at Policy Exchange. I'm really delighted to be chairing tonight's discussion where we're asking the question, what is the future for vaccines policy? Now, this discussion takes place on the back of a project that myself and colleagues undertook last year and for which we produced a final report entitled A Fresh Shot. For those of you that are in the room, a copy has been rather unsubtly placed on your seat. And for those of you joining online, you can access that report on the Policy Exchange website. And that work started by exploring what really seemed a paradox in our vaccines policy, that whilst the UK clearly has world-leading capabilities in vaccine development and indeed in delivery, there'd also been a decline in recent years in uptake across the routine schedule across key childhood vaccinations such as MMR, for instance. This context, when taken in the place of a wide-ranging discussion about our deployment of COVID-19 vaccinations, the largest vaccination drive in this country's history, and a range of other threats in the last 12 months or so, including polio in London, monkeypox across our major cities, has presented a ripe opportunity for us to discuss what will be required to ensure that we have the infrastructure and capabilities in place so the UK remains the best place to develop and to deploy the vaccines of the future. And indeed that is our focus for this evening. Rather than to question the decision making about the use of any particular vaccine or to get bogged down in discussion of any particular campaign, we want to ask what needs to be done to ensure that the plan, the infrastructure and resources are in place to boost vaccination uptake, to better meet the needs of underserved communities in particular, and to ensure that the UK is ready to roll out new vaccine technologies with a busy pipeline, we know, on the way, and the possibility of therapeutic as well as preventative vaccines on the horizon. So to consider that question, I'm pleased to say that Policy Exchange has assembled a really fantastic panel here this evening. If I start to my immediate left, I have Susan Rienow, who's the Vice President of the Association of the British Pharmaceutical Industry, and in May this year will become the President of the ABPI. She's acted as the co-chair for the ABPI's vaccine group, who are kindly supporting this evening's event and indeed have supported Policy Exchange's work in this space over the past year. Susan is also the country president for Pfizer in the UK and led their vaccines business unit during COVID-19, and she's previously held Pfizer's hospital business unit and their essential health division since coming across the pond a number of years ago. Representing one of the professional groups responsible for vaccination alongside nurses and GPs, I'm really pleased to welcome Thorrun Govind, who's the English Pharmacy Board Chair at the Royal Pharmaceutical Society, which is the professional membership body for pharmacists and for pharmacy students. Thorrun studied at King College London and completed her training at Manor Pharmacy in Newark-on-Trent. She's the former recipient of Young Pharmacist of the Year Award and was a nominee for the NHS 70 Parliamentary Awards for advocacy of the profession, a regular on TV and radio too. Thorrun was previously resident pharmacist on BBC Radio Lancashire. To my far right, Professor Dame Jenny Harries is the first Chief Executive of the UK Health Security Agency, an executive agency of the Department of Health and Social Care. She was previously Deputy Chief Medical Officer for England from July 2019, a position which she served throughout the COVID-19 pandemic before taking up her present role. She was also previously on the Joint Committee for Vaccine and Immunisation, or JCVI, and in addition to her experience in government, Jenny has extensive experience on the ground, having served as Director of Public Health in both England and in Wales. And Jenny's experience is also global and worked in policy evaluation and clinical roles in India, Brazil, New Zealand, to name but three. And lastly but not least, to my immediate right, Sajid Javid has been the Member of Parliament for Bromsgrove since 2010 and has served in the Cabinet of 3 Prime Ministers as well as Secretary of State for 6 government departments, including the Treasury and the Home Office. Sajid was the Secretary of State for Health and Social Care from June 2021 until July 2022, overseeing the COVID booster rollout and the largest flu vaccination drive in history. So it's an absolute pleasure to be able to welcome all of you here this evening. I'll be inviting each of our panellists this evening to deliver just a few minutes of opening remarks before we have a discussion around some key themes. But then I'm really keen to ensure that we draw upon you, both here in the audience this evening for a substantive Q&A section, and also really keen to bring in our online audience as well for the Q&A section. So do begin to formulate those comments into questions whilst our panellists give their opening remarks. So without any further ado, I'd like to invite Professor Dame Jenny Harries to give some opening remarks. The floor is yours.
Thank you very much, and good evening, everybody. It's a real pleasure to be here. I suppose the short answer to your question is rosy. I think the future for vaccine policy and vaccine programmes is huge. The opportunities are enormous. What we've seen in the pandemic is a wake-up, not just from the scientists who I think knew all these things were possible, and indeed many of the parts of the vaccine programme that we've implemented during the pandemic have shown just what science was going on previously. But it's woken up the idea that we have untapped opportunities to improve health outcomes, and in particular, as has just been mentioned, for those groups who perhaps are least likely to have good health outcomes and can most benefit from preventative intervention. So I'm usually pretty simplistic about how I do things. I've got 3 S's, which I like to do. Simplification. What are the things we should do to reach that rosy picture? The immunisation pathway is hugely complex, both in policy and delivery terms, and I'm sure we'll pick this up. But I think if we have a shared, simplified understanding of all the component parts, and not many people do know all of them, and I'd count myself in that, that will be hugely beneficial. The second one is surveillance. We need to understand what it is we're trying to tackle and what the likely benefit of a vaccination programme will be. And to do that, we need really good data, both from what the current position is on an infection, but actually, just as importantly, as we've seen in COVID using the dashboard, to be sure that those programmes are having an impact, where they're having an impact, and who we're reaching. And then the final point is sharing. So it is an S, it's a S, but it's a really important one. So I've just mentioned data. Directors of public health can work really well with local populations if they have the data. But actually we need to share skills as well. So I often talk about rotating skills, having people moving across different organisational boundaries between industry and public sector. And then finally, and most importantly, and there are some colleagues in the room who I've actually spoken to earlier today on this, we learnt that working with industry right from an early position is a very, very efficient and effective way of delivering really good novel vaccine programmes, and we need to capture that from the pandemic work and ensure that we can share, where appropriate and where governance, data, process and then delivery to improve outputs of all of our programmes.
Super. Many thanks. Thorrun, perhaps if I come to you.
Thank you. When it comes to healthcare, like clean water, vaccination is one of the most effective public health interventions for saving lives and promoting good health. And it's not just about what vaccination prompts. It encourages people to think more holistically about their health. So they might start thinking about vaccination, but when they come into our pharmacies, they also start thinking about weight loss. They think about smoking cessation. So really, it's about how can we encourage people to think about their whole lifestyle, and vaccination being a part of that as well. And if we think about our little ones, from a young age, we're thinking about what age we need to get them vaccinated. So it's always on our mind as they're growing up. Now, in terms of the COVID-19 and flu, we've seen our pharmacy teams almost begging to get involved with those efforts, and it was a little bit of a struggle at the start to get them involved, because we also had to think about the supply chain as well. But we've seen the success, haven't we? We've seen health inequalities being tackled because people know that they can take a walk to their local community pharmacy, which is about 20 minutes away, though that's becoming a struggle, but that's a separate issue as we've got pharmacies closing down due to underfunding, sadly. But we know that people are able to go to community pharmacies and have those conversations. But not just that. We heard from Jenny there about the efforts from different parts of the service. So we've got pharmacists in community pharmacies, we've got those in general practice, we've got primary care networks, and we've got hospital hubs as well. So this is a whole team NHS effort together, and that's why I think vaccination is so remarkable, because we all work together as one when it comes to vaccination. I'll keep it brief because we've got some more people to hear from, really. But what we're calling for is a continued concerted effort to reduce health inequalities, to increase that uptake and increase coverage. of vaccinations, and that means that community pharmacies are really key to be able to offer not just the flu and COVID that we've just mentioned. We really need clear and balanced national and local communication as well, because sometimes one of the difficulties during the pandemic was we'd hear things sometimes in the media before we actually got those comms to us directly. So we can all work together on this, and I'm looking forward to hearing more from our panel about how we can do that.
Thanks, Thorrun.
Thank you.
Sure. All right, so first of all, thank you, Sean, for organizing this session. I guess where I'll start is, if you look at the UK, there are some real significant historical successes around the area of vaccination. So, starting from Edward Jenner and smallpox vaccine many, many years ago, all the way to the Oxford AstraZeneca vaccine during the pandemic, the quality of the science here, the quality of the development in academia, in the public sector, and in industry is really quite strong. If you also look at sort of the state of affairs with routine immunizations across the UK, that's also quite comprehensive. So the NHS currently has 15 different routine immunization programs to protect against disease in this country, and the uptake and the confidence around that is also pretty strong, which of course these two things are linked, the confidence of vaccines and the uptake as well. And then of course there is also growing awareness of life course vaccination in the UK too. So whereas infant immunization is a very established practice, the idea that immunizing adults can help protect from disease is a less well-established practice. However, that's growing here in the UK. So all of these things are quite positive. However, it's also important to recognize that there are challenges. So coverage of vaccination, routine vaccination, has been declining over the last several years, and it started declining before the pandemic. So if you think about 2019 as an example, the UK lost its measles-free status, which was a disappointing outcome. And then of course during the pandemic, despite the best efforts of the NHS, we saw a further decline in this. So if you look at last year, there wasn't a single immunization program that hit the WHO target of 95% coverage. So we are absolutely delighted from an ABPI standpoint to support this report from Policy Exchange, which we think shines a really important light on some of the challenges that exist for the UK, but also we think offers really credible solutions for how we can project into the future and make sure that we really do have a world-leading immunization program here. I think if you think about the pandemic, there are two things that I would highlight from the pandemic that are really quite important. The first is it created an incredibly public reminder of the importance of vaccination to protecting and helping protect the population's health. The second thing is it also gave us a lot of learnings about the art of the possible. And I remember that phrase, the first time I ever heard it was from the Vaccine Task Force. That's not only in terms of the technology that gets deployed, but it's also the ways of working. And I think Jenny picked up on this earlier. The ability for the whole system to come together, academia, industry, public sector, against a common mission-led target was really quite important. The way that we worked together during the pandemic is something that we can learn from going forward. So if you look at the future, we have a really strong, exciting industry pipeline ahead that is designed to try to target some of the most challenging conditions that exist. 46% of the vaccines in the industry pipeline target infections that do not have today a vaccine available to treat them or to prevent them. And 80% of the pipeline as an industry standpoint is focused on adults, which is interesting given the different dynamics between childhood vaccination and life course vaccinations. So I agree with Jenny. I think the future of vaccines policy is quite positive. There are a lot of strengths for us to build on, a lot of good recommendations we think in the Policy Exchange report. And I look forward to the discussion over the course of the evening.
Good, thank you. I mean, excellent contributions already from the panel. But if I can say, I was disappointed a bit, Jenny, with what you said, because I thought it was going to be one of your S's. I was getting really excited because you said, and right at the end, well, one more S, and I thought that was it. But but seriously, look, you said at the start, Sean, about all the different roles I've had in government and things, and there's lots of memorable moments from all my time in government. But one I want to just very quickly share, because it really sort of emphasises the importance of this discussion, that as we've just heard about the pandemic and how it's really become a public reminder of the importance of vaccinations, was I remember, so I'll never forget, it was sometime in November 2021, and it was the weekend. Actually, I went home it was like on a Friday, I was leaving the office, and my private secretary had told me, look, that Jenny's team are looking at what could be a new variant. But we were getting these kinds of messages all the time. It could be a new variant, could be, and often it didn't lead anywhere. And so I didn't think too much of it. I go home for the weekend, and then on the Sunday, I get a call from my private secretary from the office saying, look, that Jenny and CMO Chris, they want to meet with you immediately. And I said, what is it? Can we talk on the phone? They said, no, we can't talk about it on the phone. They want to meet you immediately. I said, what's it about? I said, you have to just come into the office. So I get to the office and we all meet. And I think, Jenny, at the time we called it B11529, and which later became Omicron. And then what I was hearing, from our world-class experts, and that's what actually makes a huge difference here as well, that I think throughout the pandemic, we were just blessed with the best of the best. And that includes Jenny's team and Chris's team and Patrick and the others. And what they told me was that the UK was the first in the world to really identify and pick up this new variant. And they were especially concerned because it was already on very, very early data behaving very differently, as in they thought it was the most infectious we had seen thus far, which turned out to be correct. But also, most importantly, we weren't entirely sure how it was going to interact with the vaccines. I remember asking, when's it going to be here, right? Because I think we sequenced someone in Hong Kong, right? If I remember correctly, firstly, they traveled to South Africa. And the Hong Kong authorities had sequenced them, we'd spotted it. And I was told it's probably already here. I remember Chris saying that specifically, it was probably already here on our shores, and on that basis, looking at how quickly it seems to be spreading, that it is something that within, I think there's something like within just a handful of weeks, millions of people could be infected. And when I married that with, we don't quite know how the vaccines are going to work, then obviously, I was worried. But we quickly determined that although we didn't have the full data on how Omicron would work with the vaccines, it was pretty obvious that if we boosted people, especially the most vulnerable, that they will have a much higher level of protection than otherwise. And so, and then we had to make this quick set of decisions in government about whether, are we going to go for, as some were calling for, like some other kind of lockdown, non-pharmaceutical interventions they were called, or are we going to, now we had these vaccines, they very, very likely worked, and especially with a booster, are we going to focus on the pharmaceutical defenses, obviously vaccine at the top of the list, alongside that the treatments that we'd already had seen work for serious COVID cases, and also the testing as well that we had, especially the lateral flow test and all of that. So we were going to rely on the pharmaceutical defenses, or were we going to go for the non-pharmaceutical defenses? We all know that we chose the former. We were the only country in Europe that decided to do that. And within weeks, by mid-December, we had boosted 35 million people, over 35 million people. I remember in one day in particular in December, we had over 1 million people in one day in December. This was when the country was winding down for Christmas, obviously looking forward to the holidays, but we still had people working flat out to get people in to get their booster vaccinations. And I think that is important to show just the difference, obviously in this case in a public health emergency, and obviously vaccines are hugely important in a number of scenarios, especially in combating preventable diseases as well. But in that public health emergency, the difference that vaccines made to our country, to obviously people's health, to the wider economy, the differences it made socially, and in just such a very short period of time. That's why I think all this work is important, and we mustn't let that go to waste. And we must learn the lessons from all those experiences during the pandemic, and that's why this work is so welcome.
Many thanks. There's so many different themes I could touch upon, so trying to come up with just a few that we can sort of cover so many different things we want to over this conversation will be challenging. But I think one of the things that's come across in what everybody has said is this theme of accessibility in a way, and the importance of information, the data, to put in the hands of people on the front line for surveillance perspectives, the importance of accessibility of places in which people can get vaccine information. So I just wondered on that first theme in particular, Thorrun, what your sort of reflections were on how we could really bottle up some of the best practice that we saw during COVID and generally we've seen in recent years in making vaccine technologies more accessible to people, so we can reach underserved communities and really maximise the possibilities.
I was just thinking back, hearing all that, to actually what I was doing at that time, and actually having people come into the centres to get vaccinated. We were scared that we were going to get COVID ourselves. We were scared as healthcare professionals that potentially we were taking it home to our families, but also how grateful people were and appreciative of the NHS and how much goodwill there was towards us. Right now we're dealing with a lot of abuse in pharmacies, and that part of that is also due to frustration because of people accessing medicines when it comes to the supply chain and some shortages. But I think we had there something that was an exemplary example to the world of how we do things well here when it comes to healthcare. So actually, when it comes to in the future, I'd like to see more use of community pharmacies, because we also know that there is savings to be made. We're all looking at our public purse, the Treasury's counting the pennies. We know that there's savings to be made when GPs and community pharmacies do vaccines. So in terms of the delivery cost, it was about £34 in those big vaccination centres compared to £24 in GPs and community pharmacies. So sometimes we need to use that thinking of actually we can save money by using the resources already out there and making the best use of them.
Yeah, if I can, of course, maybe just I mean, I agree with all of that, and just going back to my example earlier of during the Omicron scare, that those 35 million vaccines, the boosters that were delivered within 5 or 6 weeks, that wouldn't have happened without all the pharmacies and the community pharmacies that Thorrun's just referred to. In that, I mean, I think I wrote that. Something like in England, there's like 11,000 odd community pharmacies, and 90% of the population are within 20 minutes walking distance from a community pharmacy. And just think about that for a second, just how accessible that is. It was only later in the COVID pandemic, obviously there was a lot we were learning on the job, but that we started sort of the system, let's say, started realizing that the power of all these pharmacies and the pharmacists to deliver these vaccines, their relationship with the community as well, their trusted relationship as well as their accessibility is important. And I think now as we look to the future and how do we deliver vaccines, I think that pharmacies have to be a crucial part of that, because I don't think there's any other way to do it. And not just the obvious, which is actually delivering the vaccines themselves, but also pharmacies can play a much bigger role in primary care in general, in aspects of primary care. And that's when I was in the department, I developed a plan that I called Pharmacy First, which was having pharmacies play a much bigger role, including with prescription of you'll be able to prescribe certain drugs, including antibiotics and stuff. And now you might think, well, what's the connection between all of that and delivering vaccinations? Because it is that if pharmacists can take away some of the workload that just falls on GPs at the moment, then it also releases GPs to focus on those things that only really GPs can do. And during the pandemic, we found that GPs were the best people to go into, for example, into care homes, or people that were that couldn't leave their own home, and because the GP had that relationship, the GP had that record, and something pharmacists couldn't do. So if pharmacists can relieve GPs of more pressure, then it actually benefits the whole system, including delivering vaccinations.
Yeah, I think that was one of the things that was exceptionally positive actually about the pandemic, was that ability for almost that shared record between pharmacists and GPs, and that sort of ability to have that in the time. Pretty much, I think, is a key takeaway. Jenny, I wonder if we could just touch upon this point around surveillance, because in the work that we were doing, sort of more broadly on data, ensuring that there was that up-to-date information in front of those doing the vaccinating, but also sort of that wider, really clear understanding of sort of at the sort of system level, sort of what was what's going on is so critical in building confidence as well around vaccination. I just wondered if you could expand a little bit on some of the points.
So just linking those, if you're managing infectious disease outbreaks, you always do time, place and person. That's for the infection, but actually it applies pretty well for thinking about vaccine delivery. And you actually need that in your data strands as well. And it's both for delivering the vaccination programme, but actually to support and encourage individuals, particularly those who might be more hesitant, to come forward. So you clearly need good information. It's no good just having data. It needs to be interpreted in a way which is accessible for the different groups. But it needs to be in the right places. And in fact, if we look at COVID, what we set up, the COVID dashboard was one of the most, well, I think at one point it was the most accessed website across the UK, so it's a huge success. If we now look at the other programmes, and it does show a data issue, because actually Susan mentioned 15 programmes, and I'm sitting here thinking, I think I can count 30 national programmes, and of course it depends how you count them. So everybody needs to know what it is you're counting, and to be really clear, so the data is useful. But it's really important feedback. So if you are an individual in an early phase, this is standard for any vaccination programme, and you're looking to see, do I really want this? We know that there will be the standard S-shaped uptick curve. As we get the early adopters who are out there ready to go, we saw them in COVID, you get the mass of the population, and then you'll get some late stragglers. It's how we go and buy things. We all have our own time frame for doing this. And actually that data feedback is a positive loop to the majority of the public. So as they see others come forward and the slope on the graph goes up, they see that as actually I'm going to go and join in this mass in the middle. So it's really important positive feedback for uptake. But I think the most important thing is, and this is an area where we need to go with our other programmes, it was almost instantaneous, the data that we had. So I know many scientist colleagues in industry have fed back and said, but actually on your surveillance and evaluation of the vaccines, you could do the evaluation quicker than we could, because our national data was so timely and so good. That is not what we have for many other programmes at the moment, and that is the ambition of UKHSA, to make sure that that level of data utilisation and availability is there, and also to share it freely. So I think transparency is important too.
I just wondered on that data point from the perspective of industry. I mean, like another positive during COVID-19 with the National Immunisation Management sort of service for data was that ability that Jenny's been referring to, for that real-time data to be made available to industry to support industry's work. So I just wondered if you had any reflections on that data point and sort of the importance of what we're thinking about in terms of sort of the overall approach, or if you had any reflections on the sort of accessibility of the vaccination policy.
Sure. So I think the first thing I would say is, in terms of the surveillance that was happening in the UK, I mean, that really was world leading. So I know, with sort of my Pfizer hat on, we had a direct line into Portendown at a global level to understand what was coming through from UKHSA to help guide us also on our global decision making. So it was really quite an important thing for us in terms of how we thought about developing the vaccines for the future, which is a real strength, I think, of the UK. I would also highlight, in terms of kind of data availability and transparency, to me, if you think about delivery models and how they could be applied for other vaccination programs, for me it kind of comes down to two C's, I suppose. So the convenience side of things and the confidence side of things. So, in terms of convenience, you have things like being able to deploy in pharmacies, which we agree is really quite important and is something that needs to be considered. Broader points of care for routine immunization programs. But you also have things like the online appointment system that was developed for COVID, and the transparency that every member of the population had about how many vaccinations they'd had, how many boosters they'd had, how many they were eligible for. That kind of data transparency can actually be really quite important in terms of making sure that people know what they're eligible for, make it easy for them to then be able to access care. And I think the second piece is around confidence. Being able to transparently deliver as clear and consistent information you can about vaccination is really important. So If you look at UKHSA recently had a survey of parents looking at the level of confidence that parents have in routine immunization programs. And the number is really quite high, which is great. There is a good degree of confidence in NHS decision making about the selection of vaccination programs and the deployment of those. But that's something that we absolutely have to keep an eye on and monitor and make sure that all the communications throughout the whole system, whether that be how GPs or pharmacists communicate to the patients, up to information about surveillance, and how decision making is made about which vaccines to select for different programs. The more transparency that we can create around that, I think the more confidence it will inspire in the population, which, it's something we really spent a lot of time and effort on during the pandemic, but it's something that equally can have as big an impact on routine immunization programs as well.
Picking up on that point around confidence in it, something that came out really so clearly in our work was the importance of the healthcare professionals in sort of building that trusted relationship, and whether that's the practice nurse or community pharmacy. I just wanted to ask you about the extent to which, in thinking about the challenges that we currently have in terms of capacity in the system, what the right balance is between enabling pharmacist technicians, for instance, to be able to do more vaccination, and we know that there's a debate around that and sort of challenges to it, but also real positives in terms of capacity, but then also how we go further and we enable those sort of most trusted, most sort of qualified and experienced in terms of vaccination to almost do more effectively, to be able to lead in terms of planning campaigns on their patch. I wonder what your reflections were on that.
Well, in terms of capacity, it's not just about enabling pharmacists when it comes to vaccination. So at the moment, in a community pharmacy, if you bring in a prescription for capsules, I can't, and if I've not got those capsules, strictly speaking, I can't give you those capsules. So there's other things that we can do to enable capacity within the system, because that means that I don't have to then spend time going back to the GP, wasting time liaising with prescriber for something that's very fundamental. We're spending all this time at university training actually to know what's actually in the drug. So there are things in the pharmacist's day-to-day role which we should be able to move past now. So that's one point. But two, yes, we've got to enable and support our pharmacy technicians. We work with them, and we want to make sure that we're able to deliver this confidence to patients. And it's not just about confidence, it's also a legal point as well. We're talking about consent as well. I'm in another life, I'm a healthcare lawyer, and we also have to, we're dealing with items of consent. So this isn't just about enabling our patients to feel confident about coming in to see us. This is making sure that it's what we're giving to them is right for them as an individual.
I was just going to ask you, Sajid, this sort of point around getting this balance right between kind of creating that additional capacity and then the kind of remarkable role that volunteers played in terms of the campaigns we saw, not just during COVID, and how we can take that further, because there will be individuals there who want to go further, want to do more, potentially want to have a career in the NHS. I wondered what your reflections were on both in your time as Secretary of State and then actually how we can sort of bottle that up moving forward.
Yeah, and before I answer that, can I just, on this point of confidence, just say a word as well, that we shouldn't underestimate just how important that was in for the UK. In that, one of the jobs I had as Secretary of State was obviously to coordinate with my international counterparts, so be in Europe or wider G20 and things. But I remember I would have regular, both formal and informal meetings with my European counterparts. And each time they would remark just at our take-up rate, where I think we had, of all those eligible, something like 90 amongst actually 90% take-up, but amongst the older groups, the most vulnerable, it was like 97, 98% take-up. And that's better than any other country in Europe. And certainly the further east you go, the less the take-up. And even countries like Germany and stuff had much lower take-up rates than us, Germany, Austria, and others. And why was that? I mean, there's a lot in it. One is what's already been said, and I put that at the top of the list, which is the confidence, the faith the public have in our scientists and doctors, the clinicians, the experts, whether it's the people they saw on TV like Jenny or Chris or Patrick or their local doctor, people sort of rightly take that very seriously, and those professionals. The second thing was that also, again, we shouldn't underestimate how important it was in the UK context, was the political unity over vaccination. And we're used to it because that's what we all saw, right? Not once can anyone point to a difference of opinion on vaccination policy over the pandemic between Conservatives, Labour, Lib Dem, SNP. There was no difference, right? But when you go across to Europe, and certainly in the US, right? If you look at other democracies, there were big debates amongst politicians, and whenever I had to do something new with a vaccine, so whenever I had God, I should know. What was the name of the committee that approved
JCVI.
JCVI. God, I haven't said that word, the acronym for months now. It's all coming back now. JCVI. Whenever JCVI independently would decide on, are we going to vaccinate this group or that group, and I would be like the first minister to be told about the decision making on that, and then think about how we're going to communicate that, put that into action. I would always call up within a couple of hours. I would privately call the Shadow Secretary of State. First it was Jonathan, and then it's Wes, and just tell them and say, look, this is what I've been told by JCVI. The government's decision is to accept it, and these are the reasons why. And I'd go through it, and we'd have a proper conversation. And every time, the responsible response always came out and said, look, absolutely, we're not going to argue with the JCVI. We're not going to argue with the government policy. We're going to, when you go out and say that, we're going to support you. And that's really, really important when it comes to, I think, vaccinations just more generally, not just in a pandemic context. And then also it was the information we shared. I think I think that point was made by Jenny earlier about the information I think we shared on vaccines, where it's the numbers, all the information that we were getting back. I think that's important as well. Just on your question about on the delivery side is the volunteers. Obviously, they played a hugely important role. We couldn't have done it without the volunteers. I think looking ahead, I think in an emergency situation, public emergency situation, I could absolutely see a need for volunteers again, because if you're just trying to scale up, especially in a short space, so you're probably never going to have enough people to do that. So there are definitely lessons to be learned about how we access volunteers this time round. How can it be quicker next time round? Can we have a sort of standing sort of group already of people that are ready to go? Looking at the training of that. Also, I think actually in your report here, I think you had a really good suggestion about, if I'm right, that about all medical trainees and pharmacists sort of in training, and nurses and stuff should all, as a sort of standard, be trained in how to immunise people as well. So the sort of all medical professionals, I think that things like that help. And the last thing I just thought I'd mention briefly on delivery is this point about data and communications and technology, because one of the things that we saw during the pandemic was, if I think about tech and data, was the NHS app. I think before the pandemic, it was something like, I don't know the exact numbers, like 10% of adults had the NHS app. Believe it or not, it existed before the pandemic, right? And 10% of people had it. And during the pandemic, actually, 1 year into the pandemic, by the time we were confronting Omicron, something like 60% had it, and that played a very important role in terms of whether it's making your appointments, checking your vaccinations, and things like that. And we mustn't let something like that go. I mean, it's got a much wider applicability than just vaccination, but when it comes to vaccination in general, in terms of the many vaccines we have, over a dozen to prevent certain diseases, I think that data and the sharing of that data can play a very important role as well.
Absolutely. Jen, I was really struck by something you said in your opening remarks, and it made me think back to when we were writing the report, and it was this challenge of complexity in terms of vaccines, in terms of the number of actors involved in it, in terms of the delivery, but also across government. I just wondered, from your perspective, what we need to be thinking about to really ensure that we have that focus on vaccination, I suppose more broadly on health protection, and how we can get those interfaces between the key parts of government, both on the sort of on delivery side together.
So that's exactly what we're working on in UKHSA, and I think it's one of the key deliverables we can achieve, but it is hugely complex. If you say a vaccination programme or immunisation to different people, depending on their background, they will potentially, one of my bugbears is, with all due respect to my NHS colleagues, it almost always appears as a programme of delivery in the front line. But in order to get the vaccine in the front line, a company has to have made it. It has to have started with some programs. Often that will have been going on for many, many years. It will have had to have gone through trials, which will actually also involve the NHS and wider populations. It has a huge amount of evaluation work. So we were mentioning Porton Down earlier, Susan was mentioning, where we do a lot there, but a lot of academic units across the country do it as well. I was talking to colleagues at Liverpool this morning at their new pandemic centre. And then the actual delivery of it is really complex. So it's not just getting a vaccine into the right arm, so COVID vaccine unit and what was the vaccine task force, always looking for the right product in the right place, in the right volume. Now for COVID that has been phenomenally difficult, but if you then multiply that by the logistics for 30 different national programmes, which were continuing whilst COVID was going on. The number of deep freezes, I don't know if Sedge remembers the deep freeze conversation. You would not, I'm really into complex deep freeze logistics because it's...
She is.
Yeah. I do have other things I do in my life, but this was absolutely critical because if you're trying to bring in a large number of vaccines and store them safely and maintain a cold chain which maintained their effectiveness, this is really important, and this is going on every single day behind every single national programme, perhaps not with the deep freezers, but with many things. And then, even then, we mentioned consent, really important. You can't have a children's programme and expect them just to rock up and have a vaccine. It needs parental consent. That's quite a big logistical operation. And then in the middle of a programme, when you're changing it, so we're thinking of COVID, we have a new vaccine. If you think now it's got really, really complex, we've got different populations with different antibody responses, having had different vaccines, we've got new vaccines coming on board. It was very simple when this started off. We all just wanted one that was going to save the world. And we got it, and now we've got lots, which is a great success for science, but means that the programme has to continuously be evaluated on a regular basis, and that is also happening to polio, to all sorts of other measles, mumps, rubella, HPV. All of these are going on all the time. Now, to get those programs running, and I'm emphasising this simply to highlight this great long pathway. Every time you put one of these out, depending on how you choose to give access or deploy it, you might need a single GP, for example, to give a vaccine. They can give anything off licence as long as they're happy with it clinically. But if you want to deliver a massive immunisation centre, which is what we saw, you have to have a thing called a patient group directive, which has to be constructed all legally, and this is going on in the background. So the answer to your question is, everybody, or all of the people involved in different parts, need to understand and respect this hugely long complex chain which turns back on itself, so that we've got a single version of that, and then we look to see where those different points are. And in this country we have learnt some very positive parts through COVID, but we also have some risk areas where we need to bolster some of our individuals, and we've learnt that in UKHSA. When you've got a big programme running, you need some experts in places, and you can't just create them overnight. You must develop them, retain them in the system. A very long process, but I think that's what we need. We need this end-to-end picture. Everybody contributing needs to know what's coming next in that, but also the value of each of the component parts.
Yeah, and if I just add to that, it's also important to note that it's got to be a cross-government process. Right, and what I mean by that, of course, the Department of Health and Social Security, Social Care, is responsible for vaccine policy, overall healthcare and things. But other government departments, and Jenny's just given a really good example of schools, so therefore DFE, but others like DWP, DCLG, and stuff, they are hugely important in the delivery program. And we sort of during COVID, we sort of, I won't say learned that, but I think people were sort of aware of that. But I think it became clear that had vaccination programs in the past been put together with that in mind from day one about the interactions and the teams, and like when we had with the COVID vaccines for children, the getting parental consent, and at that point about it wasn't easy to put that into place, because you obviously got to make sure you've got the consent, you've got to provide the information that's necessary. You've got to work with across government with a number of departments, and I think that's a really important lesson learned. And so that means going forward, like the governance of vaccine policy has to be a cross-government endeavour led by the Department of Health, but it has to be properly cross-government and not just siloed.
Here, that's something we definitely endorse. I'm conscious that I want to give the audience both online and in person an opportunity to ask questions, but Susan, I just wanted to pick up this question around looking ahead to the future and a really exciting pipeline of vaccine technologies. What do we need to do to make the UK the best place to develop and ultimately to deploy to vaccinations?
Okay, so I think the first thing is to say, as I mentioned at the beginning, it is really exciting time from an industry standpoint in terms of the vaccine pipeline. So if you look at the current candidates, current vaccine candidates in industry pipeline, we have about 100 of them. So it's a huge number that are going through testing at the moment. Most of these target infectious diseases that are caused by viruses. As I mentioned, about half of them target diseases that do not have a vaccine available today, and 80% of them are focused on adults. So there is a lot of innovation that is in progress that could create a meaningful difference for the future. I think in terms of how the UK can take advantage of this, I mean, there are, as we've talked about over the course of this discussion, there are a lot of learnings from the pandemic. At each stage of the decision-making process. So, if you think about beginning with things like horizon scanning, we had real clarity during the pandemic about the importance of creating a vaccination program for COVID from an industry standpoint, right? So it was very clear to us this was going to be quite important. It was clear on how to engage with MHRA. It was clear on how to engage with DHSC, with the Vaccine Task Force, with Secretary of State, et cetera. I mean, all of those things were lined up and coordinated in a way that made it very easy for industry to engage and to be able, this was the first country in which a vaccine for COVID was delivered to a patient, and that's not by accident. The system was all really well coordinated across all these different departments and all this complexity in a way that made a really big difference. And that mission-led mindset where everyone knew what they were going to contribute to something that everyone believed was really quite important for both the health and the wealth of the nation also made a huge difference. So if you think about practical application, I think there is something to horizon scanning, looking forward, what are the big public health diseases that are going to be the biggest priority for the UK? How does that line up against the products that are in the pipeline so that we have clarity from an industry standpoint about what is going to be most important for us to advance? Looking at how we can be more agile and to remove bottlenecks, so we did things like, for example, on the MHRA side, we were submitting, they were called rolling submissions. So our data was submitted in a rolling fashion. So rather than waiting for the entire data package and then submitting the entire data package to the regulator, we were submitting data as we got it. And the regulator was reviewing it as we got it. So that parallel process meant that we could operate much faster. Those kinds of things are things that we could apply for the priority areas that are going to be important for the future. And then having a really clear and consistent approach to decision making, I think, is also quite important. So, the role of the Vaccine Task Force during the pandemic of coordinating across all the different government departments was really important. And, from an industry standpoint, they were our entryway into government. Anything that was happening that we needed to happen or that we had questions about, they could sort it, they could figure it out, they could connect in with the right people. So I think, when Jenny talks about the need to simplify, that clarity on roles and responsibilities and decision-making process, timelines, what are the big priorities for the country, what are the big potential future products that are going to be most important for the country, that kind of horizon scanning and coordination across the system are areas that we've seen it once where the UK was the first in the world. There's no reason why we can't see it again, but it does require really a system-led approach to make it happen.
Jenny, those themes really chime in then in terms of
Absolutely, and I mean, I think some of the points there, one of the interesting ones is, as you often find when you work across the system, is nobody speaks the same language, so even the words horizon scanning are considered very differently. So Vaccine Task Force, Susan, I think, is what are looking out for something that's already in development, whereas horizon scanning on a surveillance and threat one is looking out to see what the threats are. So you have to get your vocabulary and your dictionaries to hand when you start these processes, which is a really important one. But I absolutely agree, and I think the vision in UKHSA is that by sharing epidemiological positions early, and those where we can see that there are opportunities. Now, there may be opportunities for disease prevention and health outcomes, but actually they could be opportunities for industry. For example, if you vaccinate differently and your population are healthier, can go to work and are highly productive, those are different opportunities that perhaps we've not really considered before. And then I think there is the other one that you just mentioned is we also share this ambition to condense, not to diminish in any way the quality or the governance around the development of a vaccine, but reduce the length, because we've seen we can do it. The Carbon Mission G7 UK leadership was to reduce that to 100 days. Now, I don't think that is possible for every virus, bacterium, or but it is theoretically possible for some using messenger RNA platforms. So I think there is a real opportunity there to do things differently, and we should just shorten these timeframes. We're actually going to be co-locating with MHRA from the middle of July. That's intentional to try and bring that closer together, which I hope will help industry. We also are working, we've just opened our Vaccine Development and Evaluation Centre at Porton, which is, although we have many points of entry in, and we actually have the Vaccine Task Force within UKHSA now, that is our front door for people to come in, so this journey through complexity could be much more efficient.
Lovely, thank you very much. Well, I'm conscious that we have about 15 minutes for questions, so I'm really keen to turn it over to you and to those in our online audience too. So if you have a question, do raise your hand. A microphone will be coming, and all we ask is that you state your name and organisation, and no question too outrageous, as our director likes to say. So perhaps we can go to this gentleman in the second row first.
Hi, Tony Hockley from London School of Economics. It's clear, what surprised me was we're talking in the past tense a lot when we're meant to be talking about the future of vaccines policy. And it was clear we had all the right ingredients before COVID hit, and the task force pulled those together and made something of it. And I fear that by gobbling up the task force into government, we've lost that mission-led approach, and the complexities that we had beforehand have taken over it again. Can we get the sense of mission back? Because it does appear to have disappeared.
Shall I start on that? So I often get asked this question, and I wouldn't like to think the UKHSA has gobbled up the Vaccine Task Force. We absolutely value our colleagues. I do think there is a little bit of realism here, and many of you will know from your own personal circumstances, when we had a new virus threat, we had no countermeasures to it and no treatments. Everybody was very focused. Resource was quite rightly distributed on that single mission. It is not possible to do that every day for every vaccine preventable disease. So there is a balance point. But I think the point that you make is there is plenty of learning, hence the past review, that we can take forward. And that's exactly what we want to do. So it can't be quite as flexible as it was, or I won't be. I know I should be in front of the Public Accounts Committee and all those processes. But what we can do is make the connections, keep them very live, keep them flexible, make sure we do keep them in. And in fact, we're a new organisation and not been around very long. But on Wednesday, for example, we've got more than 60 industry partners coming to Porton exactly to try and do this work with them. So rather than just do it on, bear in mind it was just COVID. I know COVID is a big thing, but that was one infectious disease. We've got 30 programmes running, so we need to manage that. But I think there are great opportunities, and particularly for new pipeline developments.
Do you want to comment at all on that sort of mission-led approach and how we ensure that we don't lose that, given we...
Yeah, absolutely. I mean, I think it is really important. I think what I think maybe a useful comparison is to look at the amount of time pre-pandemic, that the kind of average amount of time in the UK that it would take between a vaccine approval and the deployment of an immunization program. So the average amount of time is more than 6 years in the past. So if you think about COVID, where it was, weeks, there's a ground in between there where we could, not go as aggressively as we did in COVID, but still have a significant improvement over kind of the business as usual phase pre-pandemic. So I do think it requires a real endorsement of the importance of vaccination, the importance of prevention, political endorsement, as well as civil service endorsement around that, in order to be able to keep the focus and the energy behind this. But there is room in between where we were before and what we did during the pandemic that would still represent huge value to patients, to the economy, to the health service, et cetera.
So if we just take another question from the front, can we go to this lady in the second row, please? Just state your name and organisation first.
Thank you very much. My name is Fiona Loud. I'm from Kidney Care UK, so speaking very much from a patient charity point of view, and very grateful for all the work that all of you have done during the pandemic. My question really is that one of the things we learned during that time was, as you've all reflected on, the importance of transparency, communication and collaboration. And we worked together quite a lot, as Jenny will reflect, during that time, and it was really, really productive. And I wonder what your thoughts are about how we can continue in that way, because we're only as good as the information that we've got, but charities like ours can provide a trusted source of information to promote, whether it's vaccination, that the 7th dose of the COVID vaccine is coming this spring as an example. And so, as you can imagine, the questions will remain: is this good for me, should I be having it, etc., alongside access to all the treatments that you spoke about earlier, which were all hugely appreciated. But nevertheless, it's how we can continue to work together in a really clear, concise way that will give people trust and enable us all to do the best we can whilst learning from the most difficult 3 years some of us have ever had.
Did you want to reflect at all on sort of the importance of those partnerships at local level with the third sector?
Yes, I mean, I think as pharmacists we'd love to be out there more in the communities, but also we've got so much work going on in the pharmacy itself. So I think linking in with the local community pharmacies is a fantastic idea where you are. So in some pharmacies we've got running clubs going on, in other pharmacies we've got allotments. So there's lots of individual work going on across the country, and perhaps we need to be a bit better with that in terms of social prescribing as well. In the future we're going to have pharmacists coming out able to prescribe, but there's an important place for social prescribing. I think that's where charities and organisations outside of the pharmacy come in, because actually you're the experts in your condition and we learn a lot from you as well as to how we can best serve those patients. So I really do think there is a lot to do there as well.
I wondered if you had any reflections on sort of the importance of that partnership.
Yeah, I mean, it was, on my experience, obviously, around vaccination was largely around the pandemic, and it was absolutely crucial. The information we had, the partnership we had with charities that represent basically patients groups across the country, and many of the sort of members and supporters of charities, obviously, for various reasons, they might be more vulnerable to a particular type of disease versus another, and that's what it helped us. Obviously, we knew that as the department and as clinicians in the department, but it was the sharing of that information, then the access, and then providing. And there obviously been a lot of questions throughout the pandemic. A new variant comes along. Sadly, there's a lot of misinformation out there. We saw that with COVID. But I think going forward, now that we've seen firsthand the sort of benefits of that, it's not something you'd want to sort of recreate from scratch, the next public health emergency. It's something that you can just continue to work at and work with groups like Fiona's, with all the preventable diseases as well.
Super. Then I'll take one more question in the room, and then we'll go to our online ones. There are people waiting. So we just go to the gentleman in the third row.
Brilliant. Thank you. Doug Brown, Chief Exec of the British Society for Immunology. Fantastic report and fantastic discussion this evening, so thank you very much, everyone. I did have a question around community engagement, but I feel that has been covered very nicely, thank you. But had another question about healthcare professionals, and it was picked up earlier that actually healthcare professionals are the most trusted source of information when it comes to vaccination and building vaccine confidence. Do the panel, or anybody on the panel who wants to comment, do you think that healthcare professionals are as well equipped, trained and supported as they could be to have those possibly sometimes quite difficult conversations with parents or with individuals who might be a little bit concerned about vaccines, how they work and what they're doing once they've been injected into the body? So is there more that we can do to support our healthcare professional workforce?
Taylor, would you like to go first?
I think we're very used to having difficult and sensitive conversations. We have a consultation room that we can allow people to come in, have a chat, sit down, have a chaperone in. So we're used to having difficult conversations. But I also think the people who work in community pharmacies, for example, they tend to be from the local community and they tend to speak the same languages as the local community. They know the heart of the issues at the local community, and actually people just come in for a chat sometimes. So actually I think that's one of our key benefits, because they'll come in, they'll speak about things that are going on in their lives, they'll go away, they'll come back again. And we have that repeat sort of just drop in. It's you know, part of the heart of the community really. And then they're coming in for their medicines. They might just come in because something's happened in their life. So actually, I think we're really key to knowing what's going on and actually supporting people. And we're continuing to do this now, you know, in tackling health inequalities. So definitely important there.
Yeah, I'll just add one thing to that, if I may, which is that, I mean, not everyone, you know, will have that kind of relationship with, whether it's with their local pharmacist or their GP or another healthcare professional, in that personal relationship. Yeah, I think increasingly more and more people, probably as you go sort of down the age spectrum to younger people, are, you know, they communicate in different ways, right? They will get their information, and that includes communication with either with a healthcare professional or from healthcare professionals. And so I think that's important as well, is that, you know, whether it's the use of social media, you know, YouTube or whatever it is that younger people or certain communities might use more of, that it's important, I think, to use that. And one further point is that we found when it came to sort of vaccine confidence, I think Jenny alluded to it earlier, in certain communities it was a lot lower, especially in ethnic minority communities, especially in the British black community. And even then, we found that talking to healthcare professionals from your own community made an even bigger difference. And so we've got to take things like that into account as well.
I think we'll have the opportunity to take a couple of questions from our online audience, then I'll try to come back to you with the time we have. So first of all, we have a question from Stuart Carroll, and then from Patricia Hodgson. So we try to queue one after the next. So Stuart, can you hear us?
I can indeed. Can you hear me, Sean?
Loud and clear, Stuart.
Perfect. Thank you very much indeed. Stuart Carroll, Director Market Access Policy Affairs, Moderna, UK and Ireland, also formerly of the VTF, and doing a PhD looking at many of these issues. Great report. It's great to feed into it. I've got sort of 2 points really, just building on what Sajid just said there. Is it not really important to enhance vaccine confidence that we also look at diversity in clinical trials? You know, if you look across the industry, we only have a 6% average of ethnic minorities going into clinical trials. At Moderna, we're averaging 37%, and it's something that we consider to be really, really important for health inequalities and indeed vaccine confidence. I suppose my second question is, through this pandemic, we've learned a lot about the value of vaccination. How do we best capture that value, not just for future pandemics and outbreaks, but also the endemic world, to ensure that we are properly valuing vaccination and investing in it?
Perhaps if we tackle that one first and then go to Patricia. So Susan, from the ABPI's perspective, how do we boost that diversity in clinical trials, and then how do we ensure we really make the most of the value of vaccination?
So I guess the first thing I'd say is increasing diversity in clinical trials is incredibly important. And it's important on two different levels. So one is having a data set that actually reflects the population that is then going to be vaccinated, right? And it creates a lot of, whether it's medicines or vaccines, it creates a lot more confidence in the data set if you know that people like you have been part of it, right? But the other piece that's important is the connection in with local communities. So, you know, being part of a clinical trial is an opportunity for someone to better understand what does research and development look like, what do pharmaceutical companies do, how does innovation potentially help, which, you know, puts a more human face on the whole process, and I think, you know, creates a level of trust that's really quite important. So, you know, it's an industry challenge to make sure that we're increasing the diversity of clinical trial participants, but it's absolutely a key priority for the future.
Would you like to reflect on that question, Jenny or Sajid, or shall I take the next question?
No, I mean, briefly, I haven't got very much. I absolutely agree with Susan. It's absolutely critical. We haven't generally done very well. It doesn't matter where you look, we just haven't. We're trying to throw, again, with transparency of data, throw a light on some of these things.
And on that, what I will add, it's even less diverse clinical trials in many other countries in European countries when they do trials. And one of the things that the UK has done is champion the importance of diversity in clinical trials, whether for vaccinations or whatever drugs, at an international level through the WHO and through other organisations, because we can get more diversity if we work together with other countries.
There we are, Stuart. We have consensus on the panel. Patricia Hodgson. Can you hear us, Patricia?
Can you hear me now?
Yes, we can hear you.
Jolly good. Patricia Hodgson, UKRI. Can I just thank the panel for the focus in complexity and all that we've learned from the last few years, and perhaps ask Jenny something. On Friday, the ONS announced that it ceased its COVID surveillance service. It wasn't sure about the direction of infections, thought they might be ticking up a bit, but I wondered how that service fits into the surveillance and data sharing that you are able to continue. You mentioned local authorities. Obviously, it's ceased as far as the general public is concerned for the time being, but their website says that AXA is working to confirm its approach to surveillance, and I wondered if you can say any more about it in relation to COVID and possible mutations.
Yes, so thanks for the question, Patricia. So the community infection service we discussed has been absolutely superb. It's, although you'll hear it as the ONS, it is actually commissioned by the UK Health Security Agency, and we oversee what that delivers. It's changed slightly through the course of the pandemic. It started off, obviously you learn, and we've built that into the commissioning process. And it is currently technically paused as we're going into the warm season, so as we come out of March and into the new year, while we review exactly as you said. We do keep a lookout. We have a number of different ways for monitoring variants. So we pick up, for example, as Sajid noted earlier, we monitor really closely what's coming up. Other countries are putting up in terms of new variants on Gizaid, which is an and then we look at those quite closely to see whether we think they have changes of significance. But we also look at individuals in hospitals, for example, where they are testing, and those tests continue to go through. So Fiona will know, for example, that many of her patients who are in her group will test fairly frequently for access to antivirals. Where there are PCR tests gone through, then we put those through genomic screening for new variants. So there is a progress going on all the time, and then that translates back over to checking that the lateral flow devices continue to work against new variants and that we're detecting, and also that the vaccines are as well. So there's a whole program there around new variants. What we don't have is quite the same quantity of tests, as you can imagine. We are not testing every single member of the population. We don't do that for flu, for example. We have GP surveillance studies. We have a number of different ways of monitoring flu that feeds into a national and international program for deciding which vaccines are going to be produced for the following season. So we're in an interim position at the moment trying to say, do we think COVID has settled a little bit, and can we move to something like our GP surveillance system, our Sentinel system, and using testing from hospitals? Do we need to continue when we move into probably those later seasons with a version of the community infection survey? So that's where we are, Patricia, and we will obviously, when we've gone through that and come out the other side with the decision, we'll make sure everybody's aware.
We have time probably for a couple of questions in the room. So if we just go to this lady on the front row first of all, and then next go to the gentleman sort of in the back, the second back row, and we'll try and take them together and give them the opportunity to reflect.
Thank you. My name is Jane Nicholson, and I am the Executive Director of the European Industrial Pharmacists Group, of which the Royal Pharmaceutical Society is a member. I spent a couple of days at the European Medicines Agency 2 weeks ago, and we were discussing shortages of both medicinal products and of medical devices in particular. And the EU is very much, I can see, gearing up for local manufacture of vaccines and of antibiotics as well. And I just wondered whether shall we be doing more with vaccine production in this country. We're very good at research, but we haven't got, I don't believe, that's very much manufacturing facility in the UK. Or is it not necessary? I mean, are you coordinating with the EU already, or what's happening, please?
Perhaps while John heads to the back, if I could, Susan, you first, and then.
Oh, do you want me to go ahead?
Yeah, just
okay, fine. Okay, so in terms of local vaccine manufacturing, I mean, it is something that is continually under discussion. I think there are some agreements. There's one with Moderna that's been announced where a mRNA plant would go live. I think it's 26, 27, something like that. I think, you know, I can't comment on the question of what, you know, matters of national security, right, which is a separate question. But in terms of global supply chains and the impact of global supply chains, what I can say is the ability to source from many, many different places is really important in a pandemic. So, you know, we had hundreds of partnerships from a Pfizer standpoint with companies all around the world that we could use interchangeably as needed to be able to scale up and ramp up to the level that we needed. So whether you have a facility in the country or not, from a supply standpoint, that ability to access a global supply chain is actually quite important when you're talking about scale. And there are some benefits to having that global network in place in terms of being able to have redundancies in the system, being able to pull a component from one country or another country, depending on how it goes. So again, there are other reasons from a national security standpoint that you may want to have manufacturing in the country, but from just a purely global supply, how do you make sure that you can ramp up supply as quickly as possible and with least supply risk possible? That ability to access the whole globe is actually quite important.
Did you want to come in?
Yeah,
sorry, Sajid first, then.
Just very quick. I mean, Jane, it's a really important point you raised. That one of the abiding lessons from the pandemic is that we, as the UK, need to be a lot more resilient ourselves in being able to manufacture vaccines. And of course, that's not just the factory and things; there's the whole sort of ecosystem that goes along with that. Not least the sort of the critical supplies in that chain. And the government had spent and continues to spend a lot of time focusing on that, working on that with Jenny and her team and others, and that's why, you know, for example, you know, Pfizer has invested in the UK. Susan referred to the deal that I signed with Moderna as well, where they're going to bring in a MHRA manufacturing facility, the only one in Europe, you know, a huge one that will be built in the UK. And they'll be doing their global R&D here as well for a lot of those products that they will sell here and globally in the future. So for exactly I guess the reason you asked the question, there's been a lot of thinking done around that.
But 84% of raw materials that are used for pharmaceuticals come from either China or India. I don't know whether that applies to vaccines. It probably doesn't as much.
I don't know how much that applies to vaccines, but you're right. The broad point is correct, and that is why I think you'll hear more over time, especially with respect to China, from the government on building more resilience.
So we'll just squeeze in a final question and then give everybody the opportunity to just give their closing remarks. So there's a question at the back, John.
The chairman of Future Planet Capital. With all the complexity you've had so far, it's quite mean to do this, but actually building on the previous question, you've sorted out what we do in England, but in England we've got this great science, we've got the ability to, with Adrian Hill and the new malaria vaccine, make a difference to the rest of the world. So the follow-up here is not just on manufacturing, but how are you as policymakers going to actually connect to the rest of the world, not just for manufacturing, but to make sure we have enough when we need it, but also when we do have it, that we're able to actually spread it and ensure the rest of the world gets it too. So it's not just looking after ourselves here in the UK.
Yes, can I just add to the previous question,
Yeah.
just to sneak in on that one, because so the Vaccine Task Force actually, part of their work was exactly, this is what Sajid was referring to, so I think over 400 million was invested. So even things like companies' investments in chemical producers to get the right specialty lipids that you need for mRNA development. So there has been a lot of work on that. I mean, clearly not completely resolved, but investment in Darlington and CPI to encourage new technology development in the UK. So I think it's not a neglected topic, it's clearly not resolved. Going back to that, so I think, I mean, what we saw was differential use of vaccine. I mean, the UK donated over 100 million doses of vaccine, and I think that's important. It's a completely changed picture now, in the sense that actually effectively there is a lot of COVID vaccine in the world, and the really important point is to ensure that it can be deployed effectively to those populations who are not yet vaccinated. UKHSA has a global strategy. It works with all sorts of centres. We have a new variant assessment platform, for example, so we support other countries who don't yet have that expertise to develop their ability in genomics and new variant assessment, so they can work on this. But I think your point is actually one about investment, and Susan may want to come in, but I think what we're trying to do is assess all hazard threats in a much more consistent way than we have before. Some of those are for the UK, some of them are global, but as we've seen with things like Ebola or even Mpox, what happens overseas actually will cause some sort of impact in the UK, given our global characteristics now. And so that area, and looking at what the burden of disease is and what the impact of new vaccines could be, is something that is actually we're trying to work through now in a much more systematic way than I think we've done before.
Did you want to come in next?
Yeah, just to sort of finish up, because I think it's the last question, right? So on, I mean, yeah, it's a really good question to finish up with, because obviously we're understandably talking about the UK and our vaccine policy, but you know, these diseases, they don't recognise borders, as we've all just so clearly seen. And as Jenny's a really good example, we're one of the most connected countries, and it will, you know, whatever there is somewhere in the world, it will eventually end up here in some shape or form. And so we have a direct national interest as well as a moral imperative to help others across the world. I think two things that I would certainly say we've learned through the pandemic, and one actually just touching on the point earlier that the gentleman asked about diversity in clinical trials and stuff. You know, if you look at the manufacturers and the companies that make these vaccines, whether they're American, they're German, they're British, whatever, is basically, you know, white Caucasian people designing stuff, testing it on white Caucasian people, and then you're really focusing that, because that's where all the money is. That's how they think, right? But we need, in terms of diversity, we need to find a mechanism that rewards companies to think more about diseases that you might be able to build vaccines against in the poorer parts of the world, which mostly are not white Caucasian people run by white, you know, run companies and things. So this is a really important point, I think, that, you know, medicine just generally naturally sort of, you know, the companies will focus on the rich world, but you know, if we're going to help the poor world, we need to, they are actually not for much money, but ways that we can incentivize companies more to think about people in the sort of, let's call it the global south. And that comes to the diversity point earlier. And the second thing related to that is that in these sort of poorer countries, when you're trying to deliver vaccines, we found that the major issue wasn't actually, after a while, it wasn't getting the COVID vaccines, it was actually getting them into the arms. Right? So there are plenty of countries that we delivered, a part of that 100 million, you know, millions of vaccines, and they just rotted away in warehouses, in airport hangars, or other places, or they didn't have the refrigeration equipment when they got to the villages and things, so they didn't have a long shelf life, because they just couldn't get them into the arm. I didn't have the trained people, didn't have the equipment, didn't have the infrastructure, and that is something that is worth investing in. You know, finding a way for the rich world to invest in that, because it will pay off for all of us.
Perhaps if you had any final remarks you want to make, and then I'll give Susan the final word, and then we'll have to bring things to a close.
I don't think I've got anything further in terms of what we heard there about the rest of the world. We can't do this on our own, and we've got healthcare professionals who are also travelling the globe as well. So I think it's on us as well to help support those in other countries with their practice as well. And that's why speaking to other countries, finding out how they are doing things better than us, sharing best practice is so important. My last point really to get on my soapbox is really to say we saw something so brilliant which we can learn from in the future, and we've heard how we can learn from this. But I'm all about practical things that we can do today, tomorrow, you know. So to me, we need more national contracts when it comes to healthcare. So there's too much bittiness and regional variation, and we do need to appreciate what's going on in the regions. But for healthcare professionals, we want to enable them to move all over the country to where they are needed. So we need less variation when it comes to vaccine programs, for example. Make sure that we've got really streamlined national contracts. Make sure that when it comes to communication, the NHS app, I encourage you all to use it, because it helps us not just for vaccination, but also something as simple as ordering your prescription helps our pharmacy teams, helps your GP teams as well. So there's lots of things that we can do on an individual basis actually to support the national effort when it comes, even if you're not a healthcare professional, when it comes to vaccination and also the healthcare system. So thank you.
Still an final word, please.
Great. And on vaccine equity or closing remarks?
Both.
Okay, all right. So very quickly on vaccine equity. So I would just echo what Sajid and Jenny said. The problem is not supply of vaccines. The problem is deployment of vaccines. So it's absolutely critical that wealthier nations of the world put time and effort and money into making sure that we have a better equity across the globe in time for the next pandemic. But the key to that is going to be making sure that the systems are in place to be able to deploy the vaccines. In terms of just closing remarks, I found myself, I guess, right around the time of Omicron, in the middle of an ABPI vaccines group discussion. And I remember distinctly saying in the discussion about sort of overall immunization programs and what was going to happen going forward that I was not worried about COVID, because COVID had the energy and the focus and the entire system working towards it that it needed to make sure that we could get it done. What I was worried about were the other vaccination programs. And I think for me, that's probably surprising from the head of Pfizer to say in the middle of a pandemic, but I saw a huge difference between how the system was organized and coordinated and this mission-led approach on the COVID side, and you contrast that with routine immunizations and it just isn't the same. You have people out there who desperately need protections from these infectious diseases. We need to make sure that we offer up the same level of focus and energy and the importance of decision making and transparency for these other immunization programs that we had for COVID. And just to give you a sense, if you look at the role of the JCVI compared to the role of NICE, for example, which manages medicines, they basically do the same function in terms of making decisions around reviewing all the clinical data, deciding which interventions are going to be cost effective, deciding which populations should receive that intervention. NICE has 800 people as part of it. JCVI has 5 people in the Secretariat. So if we are going to make prevention and vaccination and routine immunizations as important as we all know they should be for the health of the nation and the wealth of the nation, it is desperately important that we take the kind of focus and energy that we had for COVID and shift it over into some of these other disease areas as well. And I think the recommendations that have been put forward by Policy Exchange give a really good starting point for how to do that.
Many thanks, Susan, and many thanks to the ABPI for their generous support of this evening. And thank you very much to you for joining us this evening. I do apologise, those of you that wanted to ask questions and weren't able to do so online too. But thank you very, very much to our excellent panel this evening who have been exceptionally generous with their time. We have gone over. But for those of you, please do join us for some drinks after this event, and we hope to see you again very, very, very soon here at Policy Exchange. Please do join me in thanking our panel. Thank you.